All right. Hello and good evening, everyone. My name's Dr. Burnette. I am a new hip and knee replacement surgeon for Southeast Orthopedic Specialists. We have to go through a couple of introductory slides that we're required to give. I was just going to give you a little bit of background. So I went to the Medical University of South Carolina, which is in the lovely city of Charleston, a very long time ago. I did my residency at Walter Reed Army Medical Center, which is located in Washington, D.C., or well, at least it was. It's now been combined with the Naval Hospital, so it's in Bethesda in a new building that I never got to see the inside of. And I did my adult reconstruction replacement fellowship at the Mayo Clinic here in Jacksonville. In the past, I did train in the Army, so I was assigned to William Beaumont Army Medical Center, which is called Fort Bliss, which we say is the most inaptly named base that we have, located in the lovely El Paso, Texas. There I was the chief of orthopedic surgery, and I spent 7 months in the lovely Iraqi desert with the 1st Infantry Division. After the Army, I first went to a place called Macon, Georgia, which is about 6 hours from here, in a private practice. And then my wife decided she wanted to live at the beach. And so I joined the Houston Clinic, which is also here in town. And then 2 weeks ago, started with Southeast Orthopedics. So the Burnette team, as we use it here, we're going to be located at the Fleming Island office, which is 4565 US Highway 17. It's right down just after Doctors Lake Bridge. There's a clock tower in front. It's the only one. You can't miss it. I have a physician assistant. She's been with me for about 6 years. Her name is Erin Smith. Most people would rather talk to her than me. She has an orthopedic fellowship as well at the University of Alabama, Birmingham, which feel free to bother her and make fun of. She also went to the University of Florida, but either one of those is perfectly fine to pick on her. So I do pretty much all hip and knee replacements. This is mostly people who have end-stage arthritis. They've been treated sometimes with physical therapy, bracing, injections, although if you haven't, we may do some of those things before we get there. Knee replacements are total knee replacements. We also do some partial knee replacements. I do most of my hips through what's called a direct anterior approach, which I'm sure some people will know what that is. We can talk about it later. I also see patients who have had hip and knee replacements who have been treated elsewhere, sometimes many years ago, and they're just getting to a point that they need to be revised, or sometimes they haven't been there long. Infections and other reasons can cause both of those replacements to be revised early. We do use Demacoplasty, which is a robotically assisted, not robotically performed knee replacement. We use that for total knee replacements as well as partial knees. Sometimes people hear that as compartmental knee replacements. Sometimes we will use them in hip replacements. It can be done, but most of the time it's not required unless you have a really complex hip problem. We also specialize in what's called rapid recovery, which now is mostly coming to you can have your surgery the same day and go home. Which has required some changes from the way we have done things in the past. If you want to reach us, we have a email that's kind of a generic one that goes straight to my team. That's burnetteteam@se.ortho.com. We just started, so we actually have a fair amount of open operating room time. A total knee or a total hip, certainly a revision, even a partial knee replacement is what we consider what's called medium risk to high risk procedure. It's an elective surgery. So everyone's going to need to get cleared by their primary care provider. And then some people, if you've had some heart problems or lung problems, things like that, your primary care provider might want you to see any specialist that you've been seeing. The goal of this, of course, is to have no surprises, so that if you have blood sugars that are difficult to control, that we know that ahead of time and can kind of control all of those things to the best of our ability. So especially if we're planning on you going home, there's no unpleasant surprise when you blood pressure is out of range or your heart skips a few beats and we go, gee, sorry, you're going to have to stay overnight. But most of the time for fairly straightforward procedures that can be obtained within 3 to 4 weeks. Most people I tell kind of pick a time frame about 6 weeks from when we've decided you're going to have your surgical procedure, because that kind of gives us time to get clearance forms done, get you scheduled, get your insurance forms cleared, all the things that kind of need to do, and nobody's panicking or rushing, because the last thing you want to hear is the day before your surgery is that, oops, you didn't get cleared because of some test, and then we have to delay your surgery. So 6 weeks is probably a good kind of keep in your mind, but we can, if it's urgent, get it done faster than that sometimes. So prehab kind of comes in and out of play. Everybody gets excited and thinks prehab is really important, and then it kind of falls by the wayside again. So mostly it's a case-by-case basis. If you've been disabled for quite a while, that you say you've been on a cane for a year or so and become fairly deconditioned, I may tell you that we need to get you into some therapy to start working on some motor strength to try to get your muscles built up before the surgery. That will make your post-operative rehab go much smoother. But most people, if you've been kind of doing your thing and it's just gotten down to you need your knee replaced, then prehab is not always necessary. So in the past, we have considered that you have to remember that most of the studies that look at what we call survival rate of the prostheses were done when joint replacements were kind of new and to kind of mature along the way. So we had frequently told people, since when they first came out, you had to be 65 years of older just to be considered a candidate for a hip knee replacement. As that has moved down, fortunately, our technology has improved. So most people with the modern implants that we have today, if you're 65 years or older, the odds of you needing it revised because you kind of wore it out is highly unlikely. They should last anywhere from 25 to 30 years, although it's not God's knee anymore. Most of them are made in a factory in either New Jersey or somewhere in Indiana. So every now and then you are going to get one that's going to wear out faster than we anticipate. If you're very young, say you had a fracture and you're in your mid 40s, certainly your risk of a revision is going to be much higher than someone who, say, is in their 70s and their activities are not so demanding. Although some 70-year-olds still play tennis and do pretty active things. But usually we feel pretty comfortable that if you're at least between 60, 65, then you're probably not going to need more than one surgery. There are some companies, there's about 6 major joint companies. There's a couple of them who have, in essence, tried to make what we call gender-specific knees. Most of the studies that have been done do not show any difference in those types of prostheses. So every implant company makes a standard knee replacement, and it doesn't really matter which one you pick. They're all going to work about the same way. So there's we divide treatment up into your non-operative treatments, including weight loss. Weight loss is a biggie. For every 1 pound you lose, your hip and knees think you lost 6. So if you are overweight and you have arthritis, you will definitely get better if you lose weight, just because the arthritic joint is carrying less weight. We use Tylenol. Tylenol is a great drug. Tylenol will relieve pain. It's not an anti-inflammatory. It doesn't bother your kidneys, and it's very good at relieving pain. You can use anti-inflammatories. People use Motrin, people use Advil, Aleve, all of those things. And they're also good treatment options for people, certainly with mild to moderate arthritis. You just have to be careful. The long-term use of oral anti-inflammatories can have long-term impact on your kidneys and your liver. So if you're taking a lot of those, you need to let your primary care doctor know about it. And they usually check your liver and your kidneys when you come in for your regular follow-ups, just to make sure. It's not something that's going to happen instantaneously. And usually if you stop taking them, it's correctable. Topical creams, things like your Asper cream, your Biofreezes, Voltaren is actually an anti-inflammatory cream that's now sold over the counter. All of those things provide people with relief. Braces, I usually tell people braces will work. There's good data that show they work, but people hate them. And if you're not going to wear them, they won't work. So I usually tell people to go out and kind of get kind of an inexpensive brace at Walgreens or Walmart somewhere that shouldn't cost you more than about 20 bucks. Wear that and see how you feel. If you realize that something a little more sturdy is going to make me feel better and hey, I can wear this, then you can get a real medical grade arthritis brace. Walking, swimming, and biking are fantastic exercises. If you have arthritis, you want to kind of get away from high impact things. Yoga has been shown to help. Physical therapy has been shown to help. People ask me, then, once you've done those things, you have to consider things like injections. We've used steroid injections for more than 100 years. You look at the data, some people show good results, some people don't. Doesn't hurt people. We also have visco supplementation injections. We took people who were young and healthy, took the fluid out of their knee to figure out what it was made out of. Lo and behold, it's ground up rooster combs. Go figure, got plenty of roosters. Those usually come in varying ranges where you get one injection and you're done, up to 5 injections given on a weekly basis. They have been shown to work in many studies. There are some studies that show they don't work so well. So we're not sure if they don't really work, or maybe we're just not so good at picking who they're going to work in. People ask me about stem cells. Stem cells are expensive. They're not covered by any insurance companies. So you're going to have a pretty big out-of-pocket cost. The data that has been published to date is not really determining anything yet. I don't think it will hurt anyone. You certainly want to kind of know who's doing it and make sure someone who is doing this and knows what they're doing is doing it. But they're not going to hurt you, but whether or not it's worth what can be a fairly significant cash outlay is yet to be determined by studies. And that's pretty much it. Once you get to that, then you're talking some kind of operative intervention. Straightforward total knee with the Mako helping usually takes anywhere between, I usually tell people about an hour. It might be 45 minutes, might be an hour 15, somewhere right in there. Hip replacement usually takes about an hour to an hour and a half. Revisions, can't really say. It just depends on how badly the joint you're revising has failed, how much bone loss there is, how many extra pieces and parts you have to take out, put in. But straightforward, what we call primary total hips and knees, they're about an hour. So I always tell people, one, don't ask me questions you don't want to know the answer to. Theoretically, it's more of a legal question than it is a medical question. If you have an automatic and I operate on your left hip or your left knee, honestly, I don't really care. If you have a right knee or a right hip, we kind of tell people they should, if possible, wait 6 weeks before they drive. Although I have people who ignore that all the time and tell me they ignore it. So I usually just tell people, if you're going to drive, get an idea of what it's going to feel like before you get out to the crazies on 295. Maybe go to a large parking lot at a church or like Walmart late at night, where you can kind of get a feel for what it's going to feel like when you move your foot kind of from the gas to the brake and how long it takes, because it will take just a little bit longer. And the studies have actually shown that what we call the brake reaction time, so the time it takes for you to go, whoops, need to stop, for you to think that and execute the plan, it does get extended, but it's measured in milliseconds. So pain management has been clearly changing a lot. We know we have a massive crisis with the opioids. We have lots of studies that look at opioids after total hip and total knee surgery, and they don't really seem to work. We try to keep people down now to as few narcotics as possible. We use regional anesthetics, so kind of they give you some happy medicine, and then they'll kind of give you an injection around your knee. to numb it up before we go back to the operating room. And then when we're doing your surgery, as we're closing, we use some cocktails that we inject into the tissues to also provide some pain relief. We use injections when we do hip replacements to kind of give people about 18 to 24 hours of pain relief from anesthetic medications. And then we try to use narcotics fairly limited. And we have some other medications. There's gabapentin, tramadol, anti-inflammatories. So then there's some cocktails that we try to use to keep you off. We've got multiple studies that show if you're taking narcotic medications for 6 weeks after a total joint replacement, there's a 25 to 30% chance that you're still taking those medicines 5 years later. This is clearly unacceptable for many reasons. For long-term health reasons, they make elderly people kind of loopy and fall down and break other things. So we really try to get it away. If you're on narcotics before we do your joint replacement, we'll usually try to get you off of those if we can, because we're also getting more and more data out now that shows if you're taking narcotic medications before your hip or your knee replacement, you're going to have a really tough time post-operatively because mostly you're already taking medicine that inhibits the narcotic pathways, and there's a limit to how much of those things we can give you. So it's best if you can get off of them, although clearly we still, as long as you understand, we'll still try, because there's some people who just aren't going to be able to get off of them for other reasons. This is another thing that's debated over and over and over again. So this is not God's knee. It's made in a factory in New Jersey, the one that I use. The more you use it, it's just like a tire in your car. If you decide you are going to go back and run marathons, you're going to wear that knee out faster than someone who does not. It's your knee. We want you to do what you want to do. I usually suggest to people that they want to cut back on high impact activities. If you play tennis, doubles tennis, golf, those things are fine. I send people back to bowling, usually within 6 weeks or so. Running on them, at least for now, we tell people it's not a good idea. But like I said, people clearly do it. Some people tell me they don't. Some people tell me they're going to do it anyway. But I think you got to think this is not something that, oh, well, my knee's going to wear out in 5 years. The newer generation of the plastic pieces that go in here, even with high activity, you should expect those to last at least 15 to 20 years. And like I said, we've got people now who are passing the 30-year mark with some of the newer generation plastics, and they still haven't worn them out.